session, Dr. Sumalata R. Shetty.
Good morning to you all. I, at the onset, would like to thank the organizers for giving me this opportunity to be speaking on this topic, which is very close to the heart. And first and foremost, I should apologize to my teachers sitting over there. Had not realized I will have my 3 teachers here sitting as chairpersons. Dr. Ramkumar, under whom I learned anesthesia, Dr. Ravindra, who was my teacher for the initial few months, and later he mentored me as a colleague, as a junior colleague in the Department of Anesthesia, K.S. Hegde, and Dr. Sudhir Hegde, who showed that it's not all work. You have to be happy and enjoy your life along with being very sincere and working. Thank you, teachers, for being there for me throughout my journey in anesthesia. And one day, I hope I be a teacher like you to my students. This topic, airway Armageddon, I found it difficult to pronounce that word. I had to go for the pronunciation in the dictionary. Guidelines to rescue. I think it's Dr. Sumesh's wordings. Thank you for the wordings and making sure that I know the words well. What is Armageddon? It's a term widely used to portray a cataclysmic battle or war that results in the destruction of the world, good against the bad. I questioned when I was asked this topic, am I good or am I bad? Then I realized we are talking about the guidelines, not about Dr. Suma. And then this was what I thought is something destructive, and guidelines come to the rescue. In airway management, Armageddon portrays a cataclysmic battle or war that results in airway-related morbidity and mortality. A simple intubation or a complicated intubation, which was unrecognized, could lead to unable to intubate nor oxygenate and cause death, brain damage, unanticipated ICU stay, and EFONA, front of the neck access. Who doesn't know this? NAP4, a largest audit of serious airway complications in the world. And it was a prospective study of all major airway events occurring in the operating theaters, ICU, or the emergency department that resulted in serious harm in the UK for a 12-month study starting from September of 2008. The complications of airway management led to the death, brain damage, need for front of the neck access, unanticipated ICU admissions or prolonged ICU stay. And as I said, 184 cases were reported, including 38 deaths. Listening to that is very scary, and that's when we all thought of how we can manage the airway better. So there is later on seen a reduction in airway management related complications, and these were said to be because of the improved success with airway management and enhancing patient safety. Innovation, tools, techniques, guidelines, research in both technical and non-technical aspects. Nasal endoscopy, virtual endoscopy, airway ultrasound, video endoscopes, supraglottic airway devices with enhanced protection against aspiration, hybrid devices, use of AI and telemedicine are some of the reasons that we have important changes. Increasing emphasis on peri-intubation oxygenation. We all have seen peri-intubation oxygenation, where you try apneic oxygenation, we put nasal, we put, wherever possible, we put in a tube or any access into the airway and provide oxygen to make sure that some sort of oxygenation is going on even during the apneic period. Recent guidelines for difficult airway management and preventing unrecognized esophageal intubations are widely available, and that is one of the reasons for the reduction in the airway management related complications. Now, key steps in effective airway management are individual willingness to train and develop skills. This is what we see when we see the delegates come in for a workshop on airway management and learn the techniques there. And importantly, you might learn, but what is the use if you are not having those equipment in your department, or it is not available, nor there is a training for that. Then there is an importance given to teamwork, cohesive teamwork. Competent airway assessment. Assessment of the airway has become very important, and it is very, very particular that the consultant asks the postgraduate, because we have, looking at the postgraduation graduates who are doing the airway assessment, so we have to ensure that they are also very well aware that airway assessment is very important. Human factors, widespread availability of guidelines and emergency algorithms, which you all are aware of, and effective tutors to teach clinical skills. Teachers are the ones who make the difference. Whatever we say, we learn from whichever teacher it is, young or old, whoever it is, they are the ones who make the difference. So guidelines and emergency algorithm, what do? They provide structured, step-by-step approaches to manage medical emergencies, ensuring consistent and timely care, systematic approach to patient assessment and intervention, prioritizing life-saving measures. A best example is a CPR algorithm. Is there anyone here who would not know about CPR? We would all be trained for that, and we would be ready. The moment somebody collapses, we are ready there, tapping and trying to wake up the patient or proceed with the required algorithm. Difficult airway algorithms provide a structured approach to manage unexpected challenges during airway management, particularly during intubation. They also outline a stepwise approach, often involving a combination of techniques to ensure adequate oxygen and ventilation when standard methods fail. The importance of algorithm shows in the standardization. It provides a standardized approach, improved outcomes. It helps out minimizing complications and improve patient outcomes, reduced errors, helps prevent errors that can occur during stressful situations. We would never say that intubation of an unanticipated difficult airway is easy, because we all know that it's a very stressful period and we'll be looking out for help. Training and simulation has improved a lot, and it's widely available, and everyone takes interest in doing this. So they also help the clinicians to develop necessary skills and knowledge. So why algorithm? Because it's standardization, improved outcomes, reduced errors, and training and simulations. The algorithm approaches to DA management, whatever the guidelines you're seeing, there are 4 steps in that. General difficult airway algorithm, plan A, B, C, and D. Plan A would be initial intubation attempts, optimizing each attempt. If the first attempt fails, call for help. I would say that this is one of the most important aspect of difficult airway management. Even today, after some 25 years in anesthesia, the moment I go in, I see if it's a difficult case, I'll inform the HOD, sir, we have a difficult case. Or if the HOD is not available, I'll ensure that one of my, even if it's the junior, oh, Murli, difficult case is there, so Murli is there. Somebody or the other is there, so please make sure that you're preparing help before you prepare the patient for your anesthesia management. Be mindful of TAM. TAM is very important. TAM is very, very, very important because it measures the life of the patient. Plan B would be ventilation with supraglottic airway devices. We have a varied supraglottic airway devices. Master one. Either it would be LMA or an IHL, whatever it is, you have to master one. You should be able to do it even with your eyes closed. Plan C, emergency ventilation or last attempts to oxygenate by any possible methods. Try any methods, nobody is questioning you, as long as there is oxygenation and saturation is being maintained. Try one more attempt at bag mask ventilation with adjuncts. Consider a different supraglottic airway device or reattempting the supraglottic airway device placement if you are finding it not in the position or saturation is dropping. If oxygenation is failing, please do not persist. Do not go on trying to do the same thing again and again and again, because at the end of it, you lose. You lose because you have lost your team call, and your call for help has not happened earlier. If you have called for help, please ensure that you allow the next person to take over, because you are tired and you're totally lost it, and then if you do not allow the next person coming in, it doesn't make any sense to call for help. If oxygenation is failing, do not persist here long, move to plan D. The plan D will be emergency surgical airway. This is a line that is done in any guidelines, plan A, B, C, D. So these are the algorithmic approaches to the difficult airway management. Now there are well-established airway guidelines. ASA updated the difficult airway guidelines in 2022. Difficult Airway Society, DAS in UK, issued it in 2015. Intensive Care Society and DAS collaborated on and brought out 2018. IDA guidelines 2016 for airway management. We have a varied different patients that we are providing these guidelines for. French Society of Anesthesia and Intensive Care released its own guidelines in 2018. CHEST and American Society guidelines are also available. Being an IDA member and being from a place where IDA grew, I find it an important aspect or reason to take up IDA. If you go to the IDA, aidaa.in, you will find the guidelines available. These are 2016 guidelines, so be prepared to receive the 2025 guidelines in the near future. We have guidelines for difficult intubation adults, for obstetrics, pediatrics, ICU, extubation guidelines, and emergency ICU guidelines. Key steps in effective airway management: individual willingness to train and develop skills. We might bring any number of equipments, any number of skills, but unless you are willing to train and develop your skills, it is of no use. Equipment availability and training time that has to be kept assigned for the department, for the post-graduation, even for the consultant. Cohesive teamwork as an important backbone for a difficult case management. Competent airway assessment becomes the backbone again. Human factors, I'll go into the depth of human factors that affect it. Widespread availability of guidelines and emergency algorithms, and effective tutors to teach clinical skills. What are human factors? I had asked this question to my esteemed teacher. Sir, everyone are talking about human factors some 3-4 years back. What are they? Leadership and followership. It doesn't require you to be the leader all the time. You should be a team member also. It's crucial for teamwork and decision-making under pressure. Communication skills, essential for clear coordination and patient safety. Self-awareness, recognizing limitations. If I'm not well aware about surgical airway, I call in a person who can do that better than me. Recognizing limitations and seeking help when needed. Simulation training, vital for developing and maintaining airway management skills. Preparation and anticipation, critical for ensuring patient safety and satisfaction. Please remember, it is finally the patient safety that is very important. And rest comes. Failure to prepare is preparing to fail is what is being said. So this should be our mantra, to not to fail. Future of airway management: prevent complication, improving outcomes and saving lives. Key areas of focus including difficult airway management training, advanced airway techniques, and the impact of specific tools and strategies. Need to realize that DA has higher complication rates and mortality. Advanced airway techniques like endotracheal intubation and surgical airway has to be taught and learned. Research to explore effectiveness of different techniques, including RSI and supraglottic airway devices. Role of technology, use it as much as possible. We have ultrasound, we have video laryngoscopy, we have CT scans, MRIs, endoscopies. Role of non-technical skills such as teamwork, communication, crisis management in successful airway management. Patient safety by optimizing airway management, strategies to minimize complications and improve patient safety such as apneic oxygenation and pre-oxygenation techniques. Specific patient populations such as the critical ill patients in ICU, pediatrics, pregnancy, obesity needs attention. And in conclusion, broader implication of the difficult airway guidelines, especially at local institutional level, needed. Implementation in the community, anesthesia information management systems with hard stops for airway examination documentations. We should familiarize and practice with locally available airway equipment and appropriate airway cart. Take-home message, master one guideline, master one equipment, master airway assessment, master airway cart. Know your cart, master communication. Be a team leader and a team member. Thank you. Enjoy our beaches.
Thank you, Dr. Suma, for that excellent coverage. Crisis in anesthesia is one of the common sources, or probably one of the most important sources, airway management. It can occur even in an apparently normal airway, or it can happen in an elective situation. The key to prevention is probably one of the keys to prevention is application of guidelines. And the beauty of guidelines is more we apply, more we learn from that. Dr. Suma has covered very well, and one thing is cognitive aids are very useful in this crisis to prevent the catastrophe. One of the examples is the vortex approach, which highlights the key components of the crisis in a pictorial way with explanation. Thank you.